Much, sir, and thank you, the wonderful panel, for having my talk in and difficult situations in ICL surgery. Now, in ICL surgery, which is usually a very, very sweet and a safe surgery with very good results, and next day itself, patient is seeing very well. But even during these very quick and swift surgeries, we have problems. So I will take you through a few of these problem situations which we have had, and here are they. So this is a very, very poor case in which the ICL got stuck in the edge of the wound, and it took us quite a while with the ICL stuck between the cartridge and the applicator. So this you cannot happen usually, but once it happens, one has to be very careful that the ICL, which is usually a very soft and a very gentle thing to implant, does not get torn. It has great advantages that it is usually quite pliable, but the loading is very important, and this is where one needs to pay attention that if the loading has been good, these problems do not occur. Let's see this another situation in which this ICL actually had a problem just because the pupil was not well dilated. And you can see that the pupil is not well dilated, and with the ICL trying to go in, it is becoming more and more difficult. Now, in such a situation, if the viscoelastic is placed and it goes underneath the pupil, the situation becomes even tougher. And then you have the popping off of the iris, which has to be reposited extremely carefully, because let us remember the volume of the anterior chamber is very low in these patients. You have the lens in and you have the ICL in. And if there is viscoelastic underneath the iris, then the pop out of this mid-dilated iris is something that can happen. But very gently, it has to be removed, the viscoelastic has to be removed, and then it's how it is to be dealt with. Let's look at this situation. Now, for every surgeon who is doing ICL, the biggest anxious moment is when the ICL is unfolding. And if it is the new surgeon, then the ICL unfolding has to be taken and it has to be done. Now, here is a patient in which the ICL just got stuck in the wound. As you can see, it is half folded in, and my heart is in my mouth, and I hope it is not going to unfold upside down. So I have that spatula, which is, and I'm trying to push the ICL in from the main pore so that it goes in and it unfolds the right side up. So this is a very, very gentle technique, and once this is done, because as you could see that it was half upside and half downside, it could have really just rotated and it could have gone the wrong side up. So these are again situations which do not happen, but when they do happen, they have to be taken up very well. Let's look at this third situation, and here we have a situation in which it's an ICL exchange because a wrong ICL was placed in, and that ICL had to be removed because there was a refractive surprise. So removal of the ICL again is not a very difficult proposition. However, it has to be done extremely gently, and the lens focus itself is very, very important. So hand over hand technique is important. The pupil times tends to become smaller, as you can see here, but the grasp of the ICL, of the haptic, is very important. And once it is grasped, it can be removed very, very well. So atraumatically also, and then of course, as you can see that the down, and we have to place the the right ICL in, and again it is toric ICL. I need to see also the markings on the ICL so that the toricity is maintained. So once this goes in, again, once the ICL is in the anterior chamber, you can place in viscoelastic, and that dilates the pupil with a little bit of excess viscoelastic in the anterior chamber between the ICL and the cornea. And after that, very gently placing the ICL again back into the sulcus. So it takes a little bit of maneuver, but it has to be done very gently. And if it is done gently, it can be atraumatic. And this was of course a patient in which this was done years ago, and which we implanted the the V3C lens. And here I'm doing a PI, and I've stopped the video in the PI. I just wanted to make a small point. Even today we have to do a PI for the hyperopic lenses, hyperopic ICLs. So here I'm just trying to show you a technique in which the PI can be made a little differently, and it can be very peripheral. How? So the position and the incision of on the cornea for the PI is taken at a direction so that the side port incision approaches the periphery. So it is a counter of what we usually take when it's a cataract surgery and a PI to be done. So it is approaching the periphery, and then the iris, the base of the iris is pulled up very, very gently, because if it is pulled up very hard, then it can cause bleeding. And then a snip is given, and that's how the PI can be done. This video is another small video that I'd like to take you through. So this is a patient again, which had an ICL, recovered excellent vision, and had no treatments for the periphery, which was very good in the retina, but developed a retina detachment after 6 months, and a retina surgery had to be done after 6 months. So with that in place, now the patient settled retina post-operatively, but again, after some time, developed a full cataract and an intumescent cataract, which you can see here. The ICL is very much in place. Why should intumescent cataract develop so early? And that was a question that we all asked. Was there a lens touch during the vitreoretina surgery? So in any case, we had to remove the lens, we had to do the cataract, and we remembered that the possibility of possible touch of the crystalline lens was there during the vitreoretina surgery. So removing the lens again was more or less as we have been doing, and it can be done quite atraumatically. But in this patient, I was very, very skeptical whether there was also areas of synechia. So if there are areas of synechia, how was the anterior capsule going to behave when we are going to do the anterior capsular excess? So this lens, once it is taken out, it comes out quite well otherwise, and hand over hand technique, and it is out. But where the apprehension is the capsulotomy that is going to take place, and what lens do we have to implant in such a case? Remembering the fact that possibly there is a dehiscence of the posterior capsule, and the capsule might give away. So we went ahead and tried to do the capsular excess. And here, as we do the capsular excess, it's becoming a little difficult, and I'm not able to do a very good capsular excess. And as we try and carve out the capsular excess, it tends to run out. So here is when there is a failure of a proper capsular excess, and now what to do. So in fact, the capsular excess runs out in 2 places to the periphery. So we have a situation where there is possibly a dehiscence in the posterior capsule, and we have a rhexis run out. So very, very gingerly, we try and take out the lens matter, which is otherwise very fluffy. And once the lens matter is removed, now we do understand that a single piece lens cannot be placed in such a bag. So if a single piece lens cannot be placed, we have the multi-piece lens ready, and there we see that there is a posterior capsular thickening and a fibrosis in the posterior capsule where the lens touch would have taken place. And gradually we are able to remove the cortical matter, but this is very central. So what do we do? Because if vision has to come for this patient, something has to be done for the posterior capsular fibrosis that is there. So we place in a multi-piece lens in this case, and obviously we do not know where it is going, maybe half into the sulcus, half into the bag, because the bag, again, as we realize, is open in two places. So we place it in, it settles quite well. And the next thing that we need to do is to do something for the fibrosis. Now we take an MVR knife and go through the fibrous posterior capsule, and then with the vitrector, we carve out a small area of the posterior capsulotomy, and removing that much, but keeping intact the periphery of the fibrous area. Because let us remember that the anterior capsule is not intact and it has run out in two places. So all very gently, we are able to remove the central part of the posterior, which is fibrosed, and just about an area has been removed through which possibly the pupil, even when it constricts, will be able to, the pathway of the light would be uninterrupted. So we have this patient done, and the patient finally is able to get back 6/24 vision, which was what the patient had post vitrectomy, post RD surgery that he had undergone. So thank you very much for your patient hearing, and thanks for letting me share these small videos with you.
Yeah, thank